Okay, so good afternoon, everybody. We're just a minute past 1. We'll make a start. Welcome to the October meeting of the Integrated Care Board. Good to see everybody, and thank you to everybody who is joining us from the general public. A warm welcome to you. Just as a reminder, Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public. They are not public meetings. So if colleagues could all ensure that the cameras are off, except for the chair or for anybody presenting as we get into the meeting agenda items. And please ensure if your microphone is on mute. We'll get a better sound quality. The meeting is being recorded for transcription purposes, so I'm hoping everybody is happy with that. And questions that have been submitted in advance of the meeting will be addressed shortly, but I will return to that at the end of the meeting to give anybody an opportunity to raise any questions that they wish to raise on any item that's been discussed on today's agenda. So we'll take apologies if we can first. So we've got apologies for Heather Johnston, and Lynn Tolley, I think, is attending for Heather. John Rouse, Patrick Flaherty, Julie Holder, and Paul Edmondson-Jones, and I believe Rachel Gallio is attending for Paul. If I could take you to enclosure 1, which is the Leadership Compact. You'll see the compact within the papers at enclosure 1. It's a very important document that's used in all of the meetings transacted by the Integrated Care Board. And it's used to guide the way that we conduct our business, and we'll return to that at the end of the meeting. So I'll just pause there. Peter, you've got your hand up.
Yeah, so it's in terms of apologies. We've also had apologies from Paul Brown. I don't think you mentioned Paul at the beginning, so Jackie Charlesworth is attending on Paul's behalf.
Thank you, Peter, for that. Yeah, I had received Jackie's attendance. Can we just check, Paul? You indicated at the start of the meeting we are quorate, so we'll move forward that is the case, and we're able to take any decisions that we need to take during the course of the meeting. At enclosure 2, we've got our conflicts of interest register. Just double check any conflicts of interest in relation to any items on the agenda today. Please declare them now. Thank you. If we could then go to enclosure 3, paper A, the minutes of the meeting held on the 21st of September, and just go through those for accuracy first. So page 1, page 2, page 3, page 4, page 5, 6, 7, 8, 9, and 10. Everybody happy with the content and accuracy of the minutes? Thank you. If we can just go to the action log, enclosure 4. From my reading, the action log is complete or on track. So unless anybody wants to raise any issues on that, we'll move on. So Tracy, if we can move into any questions that have been submitted in advance of the meeting from any member of the general public.
Yes, okay, Chair, thank you. I was just saying, yes, I was just saying the action is complete in contacting Mr. Syme. So just for completeness there. So we've received one question, and that's from Stephanie Thompson from the Stroke Association. And she asks, given that stroke is a leading cause of death and disability, with stroke survivors leaving hospital with an average of 7 disabilities, many needing complex and lifelong care and contributing to delays in discharge and pressures across the health and social care system, how does NHS Staffordshire and Stoke-on-Trent Integrated Care Board plan to appropriately fund and resource the integrated stroke delivery network as the essential delivery mechanism for meeting guideline level standards of care and achieving the long-term planned stroke commitments? That's the first question. And do you want me to, it's a multiple question really, so do you want me to ask them all?
If we take them, Tracy, and then I believe Rachel will probably respond to the question that's been raised.
So that was the first one. What protection and security can you provide to the committed and valuable stroke network staff who are working tirelessly to improve the quality and safety of local services for this clinical priority?
Okay, thank you, Tracy. Rachel?
Thank you, and thank you for the question. Stroke is obviously a key priority as part of the long-term plan. It's as a clinical priority within the ICS. It's part of the long-term conditions portfolio, which is driving the strategy for stroke and long-term conditions as a whole. So some assurance that is being taken through there, and we have that structure in place and working with all of our partners across the system around this. In terms of the integrated stroke delivery networks, they are a key priority nationally, and we are part of the North Midlands network with that. Looking with, again, across regionally, across the full pathway approach. So looking through prevention, through optimal diagnostics, early detection, treatment, working together around the hyperacute stroke pathways, all of that being really important. So in terms of the question, we are part of that network. We are completely committed to that network. Stroke is a key priority for us, and we will continue to build the partnerships and working together to make sure that that is continues to be a priority, and for the ICB and all partners in the ICS.
Thank you, Rachel. And once again, thank you for the question that's being posed. We'll move on. Tracy, any further questions that we've received from any member of the general public in advance of the meeting?
No, Chair.
Okay, so we'll return to opportunity for anybody to ask any questions on any item discussed during the course of the meeting at the end. So if we could move on then to enclosure 5, the Chair and Chief Executive report, and I'll hand over to Peter in a moment just to go through any aspects. I just wanted to pick up a couple if I could up front. I think everybody will be aware under item 2 there that as at month 5, the system level, we're reporting a year-to-date deficit position of 58.6 million, which is a 45 million adverse variance against the 13.6 deficit plan. Clearly, we've got an important item on the agenda in a moment, the system recovery plan, which we will go through. But clearly, a lot of work needed and going on across the system to actually examine the underlying issues for the current position and to do all we can to mitigate and improve that as we move forward. Second thing I just wanted to pick up was the issues around Wally's Quarry. People will be aware that there's been issues ongoing there in the Newcastle area for some time. And I just wanted to recognise the work that went on between the ICB Medical Director, the GP Federation and the LMC in the north to actually assist with managing some of the concerns that were raised by the resident population there. So I just want to thank everybody involved there. And just finally from me, the maternity and neonatal independent senior advocate appointment, really welcomed and pleased to see that within the report. So Peter, if I can hand over to you to pick up any other exceptions that you want to raise from the report.
Thanks, David, and afternoon, everybody. So firstly, I'd like to, I suppose, reiterate the point around the financial position. So clearly, as the detail describes in the papers, we are not in a great position, and we are behind where we expected and wanted to be in the plan at this point in the year. And the situation is unfortunately compounded beyond the risks that sat within the initial plan by additional inflationary pressures, which many parts of the country are seen in terms of the ICB situation or ICB's situations. However, we are absolutely being impacted by those, plus a small number of other items. So the situation financially is extremely challenging, but and the recovery detail is within the papers, and Jackie will talk to it in a little while. I'm really pleased with how the system has come together and operated in unison to build a collectively signed off, collectively agreed and supported recovery programme that's got a number of elements to it. But most notably, perhaps, those elements are as operationally, clinically focused as they are financially focused. So very much operating on the basis of, true transformation in the broader sense. So that's really positive. But what I would add to that is that we're not resting on that plan alone, and we continue to have conversations, whether it be as a group of chief executives or executives more broadly across the system, about what else it is that we can do to mitigate that financial challenge. The second point is around urgent and emergency care, and we are seeing right here, right now, actually, really significant pressure across the system, notably within University Hospital North Midlands, unfortunately, but more generally as well. And we're working hard, again, as a collective, to make sure that we address that situation. There are a number of factors that have caused the current pressure that we've got, but I think for me, it reminds us in a timely way of the importance of working as a system collectively, that distributed leadership principle that ICSs are fundamentally all about, to make sure that we mitigate and manage pressures that will inevitably build as we go into and through the winter. So a big thank you to everybody that is currently involved in mitigating and managing the UEC challenges that we are seeing at the moment. And a big thank you to everybody for their collective efforts in terms of that distributed mutual accountability piece, both on the financial position and the UEC position as it stands. I'll leave it there, David, if that's okay. Happy to take any questions.
Thanks very much, Peter. Just pause there. Anybody wants to make any comment on the report? If not, then we will move into enclosure 6, the system recovery plan. And Jackie, thank you very much for joining us this afternoon to take us through the report.
Good afternoon, everyone. Good afternoon, Chair. So in terms of the recovery plan, this has been worked on for a number of months now. I think it became very clear that we were going to be struggling for this financial year in terms of meeting the plan. And as such, the recovery plan was started to be developed very early in the year, starting at an event on the 14th of July. And the event of the 29th of July sort of took those areas further. From those events, we've got sort of 7 big ticket items, and I think the work that the teams have been doing in terms of getting the granularity around what the deliverables are, what's measurable, and what the milestones are, has really come into fruition now. One of the things that we are very mindful of, though, is of course overestimating some of the elements, so that the way that we're working through the metrics is to make sure that we recognise the risk of double count and that we eliminate that from where we're looking at. The issues, I think, around all of this is, have we got the resources to be able to deliver these big ticket items and the milestones that we need to do? Have we got the workforce and the capabilities to actually move as fast as we need to do to turn around the position? The position has been discussed with NHSE. They're very well aware of it. We will be probably very soon getting some support to come and investigate what our risks are, whether we've identified everything correctly, and whether we are doing as much as we possibly can do to achieve a better outcome this financial year, and therefore move on with a much better footing for the next financial year. Can I take any questions?
Thank you, Jackie. Just bring myself off mute. Jackie, I've got some questions, and probably Peter, the question maybe for you before I bring Megan in and the executive team, the wider executive team. Just in terms of the granularity and the run rate delivery now against the big ticket items, if we just get some assurance that the plan is there. I'm aware that there's been a great deal of work undertaken, as Jackie described, shared with NHSE has been also described. So when will we begin to see whether we are, flatlining certain things or beginning to turn off some of the extra expenditure?
Yeah, no worries. I can start with that, and Jackie, you may want to add. But in very, I suppose, headline terms, we are already seeing that improvement, that flatlining in terms of the continuing healthcare spend. So the significant increases, both in terms of volumes and inflation that we saw through until the summer, essentially, have been mitigated over the last couple of months. So very initial. Very initial data and indicative to an extent, but it does clearly indicate that the actions that we've been taking are starting to bite, are having an impact. In terms of the granularity of all of the 7 programmes, the event that we held, I think it was about 3 weeks ago, that essentially showcased the work that's been done in each of the 7 areas and asked leaders from across the system to basically test those people that are responsible for each of the 7 programmes as to whether they're working on the right things, going into the right level of granularity, the milestones are where they need to be, etc., etc. So really get into the detail. That they essentially passed with flying colours. So the conversation that concluded with a question to the audience, all executives essentially in the system: are you content with the clarity and level of detail for each of the 7 programmes? That the view was in the room, yes. So, that gave me a level of assurance, and hopefully others in the room, a level of assurance that the detail is either there or very much being worked on. So I wouldn't want to leave the audience thinking that it is all done and dusted. There is still work to be done. But what has been done over the last few months, I'm assured through conversations at system level and looking essentially at the detail, that we are in a good place.
Okay, thank you, Peter. Second point, just wanted to raise was the linkage back to stakeholder boards, and just again for the board's assurance today that regular feedback through the Chief Executive Group is taking place with our stakeholder partners.
Yeah, so what I would say, and I'm happy that others come in at this point, of course, but we do have regular conversations through the CEO forum, some quite granular in terms of specific things and others more broad in terms of progress to date. And I'm sure next week at the Chief Exec Group, we will have another conversation about the recovery programme. So that does occur. Obviously, in terms of conversations within organisations, I would struggle beyond the ICB to comment on that. But I am aware that the CFO forum, for example, is absolutely immersed in this. And my understanding is that, they're operating in unison in terms of the discussions, debate and the agreements, and perhaps probably the deputy CFO group, which Jackie, you're of course part of, operates in a similar way.
Okay, and then just 2 more quick ones if I could. The next one is within the 7 big ticket items, there obviously isn't a workforce stream. So just given some of the scrutiny, and this is more nationally as well as locally, on agency cap and bank spend, just wanted to check that is adequately picked up across the 7 streams, or whether you've given some thought to actually adding that stream in. So Mish, I take it your hand is up to give me assurance on that. Yeah. So Mish.
Thank you, David. And yes, we are considering whether we do need to have a separate stream for workforce. Throughout the process of developing the recovery plan, workforce have been very much engaged. And to talk to your question earlier about committees, we are absolutely engaged in the conversation at CPO level. We have regular conversations with CFOs, and those decisions that we make and the action plans are taken through our governance committee to the People, Culture and Inclusion Board. In terms of the specific workforce programme, we are now considering whether we do have a separate stream, and those conversations are ongoing. Regardless of it, the work is happening and will feed into that governance process.
Okay, thank you, Mesh. And just finally for me, and then I'll bring Megan in, is the alignment, excuse me, with the other subcommittees of the board. So in terms of ownership of the recovery plan, that it's not just going through finance and performance, it is linked into, you know, people committee, quality and safety committee, etc. And that again, stakeholder component parts are actually linked into those groups. So it's got wider ownership rather than just being seen as something that's being dealt with through the chief finance officer or that route.
I mean, certainly I can confirm that Paul has been going through various forums to share the recovery plan and the with all of those forums. So just recently he went and met with the LMC. We're meeting with the primary care PCN directors tomorrow to make sure that that all follows through. Again, you know, it's been a big part of the team briefs that we've had. It's probably come 2 or 3 times now to the team briefs. In terms of the formal forums, I can't necessarily confirm that would have to be by the exec directors.
Okay, so Peter, just bring you in, but just assurance that you know, it is widely socialised and not just going through the money finance route.
Yeah, so the System Performance Group has regular conversations about the recovery programme, and that includes a myriad of executives predominantly from across the system. So not just chief finance officers, but chief operating officers, chief nursing, medical, etc. So in terms of the broader cadre of execs, that absolutely focuses, you know, their attention through that forum. The Finance and Performance Committee as well regularly reviews this and has conversations about it. We've mentioned the Chief Exec Forum as well. So it does have a broad distribution, I think, when it comes to, you know, being able to disseminate and discuss progress with it. I'm sure we could always do more, and if there are any suggestions in terms of other mechanisms and processes. The other thing I would say is that the leadership across the 7 work streams is distributed across the system. So this absolutely is not a ICB leadership piece playing out. So an example of that, and I'm sure Richard wouldn't mind me mentioning, is that Richard Harling from the County Council is leading on the care home element of the programme. We've got providers also leading on other aspects. So, you know, it's distributed in a very pure sense across the system.
Thank you, Peter. Bring some questions in now if I can. So take Megan first.
Thank you. Thanks, David. Thanks, Jackie. It's really a comment on the back of the question you just asked, David, and Peter just answered. Because for me, this recovery is very much around financial and performance recovery. It's not just a financial recovery programme. I think it's really important to emphasise that and set out on page 12 and 13 of the slide pack. The KPIs there are very much around delivering improved services to people, looking at services around fall support for our care homes and around end of life care. So I suppose that was the comments I wanted to make. The question really was around how we are ensuring that the clinical review process actually sits closely with concerns around delivering the financial improvements that we need to make. How that financial recovery sits closely alongside safe service provision.
Thanks, Megan. So Peter, do you want to take that, or Jackie?
I can begin. Jackie may want to add, and also I think we've got Becky on the call, who's acting CNO for the meeting. So essentially, the quality impact assessment process that we've got and is well established within the organisation is applied wherever we need to apply it. So if there's any indication that there is to be a quality impact, however, small that may be, QIA process essentially just kicks in, and that does what it needs to do. In terms of then flow through the quality committee, again, Becky might have a view on that, but there is something about making sure that there's a parallel set of conversations here, equally through finance and performance at the same time as the quality committee. The initial comments from me, but Becky, you may have more.
Yeah, no, Peter, don't disagree with what you've already said. We do a quarterly report that goes to Quality Safety Committee that undertakes to give advice of those that have been a senior panel and those that have gone through in terms of the Gateway 1, so have already received approvals and comment, and it seems it's in our report actually that we are in month 3-4, and we've already made some changes in terms of that process following feedback. So if there is something in terms of connecting the dots across the whole of the system, then I think it's really valuable that we take that on board and actually do something with that. Sort of, we've not got everything set in stone, and we've always said it's an iterative process in terms of the new QIA process.
Thanks, Becky. Megan, thanks for the question as well. And obviously, through quality and safety, constituent partner members attend that meeting and presumably feed back into their respective organisations.
Can I just confirm as well, when we're looking at continuing healthcare, we have daily meetings, but they're not about cost. They're about the quality and the appropriateness of care. What's happening is that once the appropriateness of the care that's provided is worked through and challenged, actually then some of the costs have come through. But it is not a cost-driven meeting. It is a care-driven meeting, and that's where I think we're beginning to see some green shoots around continuing healthcare. It really is like stopping an oil tanker and trying to make that difference. But we are starting to see things flattening out and making that difference. But it is by putting an awful lot of time and energy into care that is doing that.
Thanks, Jackie. That's a really important piece of assurance that you're giving the board this afternoon. Josie?
So a lot of what I wanted to say, David, has been said. I was actually put my hand up in response to your original question about where the quality and safety connectivity is. And obviously, we've also got joint NED. Both Megan and I sit on both committees in our respective chair and second NED kind of role. So we've got that, absolute sort of connectivity. But I have got a question, if I may, and I just wondered, looking, and if I've missed it in the papers, forgive me, there's a lot of detail there, but I was just wondering about the connection to the Clinical Senate and being sure that we've got a Clinical Senate view on some of the changes that we want to make. And apologies if I've missed it, but it just didn't spring out at me, and I just wondered if anybody could comment on that, please.
Thanks very much, Josie. Rachel?
Yeah, so really good question, because we've actually been really close to this from the very start. So Paul comes to the Senate every month. So we've got the senior health and care leaders on that board. So it's been going through there every month. The other thing is around the leadership of these programmes. They are being clinically led, and Paul Brown's been very clear that from the start around those programmes, when you do the right thing for a patient, it's often the most cost-effective thing to do for the patient as well. So throughout, it's absolutely running through all of these programmes is the clinical leadership around this. So to be absolutely assured that Paul has been coming to the Senate for over a year now, and as part of that now he brings the recovery programme to it, so it will be challenged and supported through there on a monthly basis. So absolutely, and he came last week to that.
Rachel, again, thank you for that. That's again really strong assurance back to the board today, and something we'll obviously keep under review as we move forward with this challenging set of events. So if I could just pause just to give any opportunity to any chief execs on the call who may want to make any comment or contribute to any part of this plan before we move to the recommendation. Okay, everybody happy with what's been said? And by that, I'm assuming everybody is aligned to the plan and the route that Peter identified a few moments ago. So in terms of taking this, we're taking assurance from the progress being made. And again, just re-emphasising that clinical leadership, managerial enablement that's going on around the plan, and to ratify the decision of the Finance and Performance Committee to approve the recovery programme. There will be a meeting taking place within the next 3 weeks to bring senior system leaders together to just do a little bit more assurance around this, which will come back to the board next time. But if the board are content with that, then the recommendations that I've just outlined will move on. Okay, thank you everybody for that very helpful discussion. Jackie, thank you very much for coming and presenting that for us. Okay, we'll move into enclosure 7, the quality and safety report. And Becky, are you taking this? I had assumed Lynn was coming, not you today, but great to see you and welcome.
Thank you so much, Chair. And yes, pick the report as read, so I'll just pick out some of the highlights that were in the document that you've received. We have identified through the risk register that there were no further risks that were identified at the quality level over the last month or so, and we have had further discussions about the system approach to the AHA, RHA looked after children reviews, and there are further plans and mitigations being put into place to address those. Positive news from a maternity perspective, there's money's been identified by government for additional obstetric and neonate consultants, which has been enacted locally. I'm aware that interviews have already taken place for the neonate consultants to try and bolster that staffing environment in particular. And a recent review meeting, assurance meeting that we had over at the maternity unit at Royal Stoke was positively received. Both the team and NHSE colleagues who visited there identified that there were significant improvements being undertaken, and actions that were associated with both CQC and Octon report are becoming embedded. We've also got Health Watch who have offered to support and do the walk with the maternity and the neonatal services, and that's going to be enacted in the next coming months. Also making people aware that we've got NHSE visiting again in our maternity services early November, and that we've got the oversight meeting which has been put into place. I think we're now on our second meeting going into our third, and that's been commended by NHSE who have participated in that on the collaboration and the support from a system perspective. So all positive from that point of view. I'll draw attention to the fact that UHDB had a CQC visit within their maternity services recently. It was undertaken at both the Derby and the Burton site. We're awaiting for the outcome of that report, but UHDB voluntarily participating in the support mechanism that's put in there to help and embed any changes that are needed to improve services. From a safeguarding perspective, our provider collaborative plan continues to progress. There are 2 specific areas of note which the safeguarding team are working together on. One of those is the working together to safeguard children consultation, which is driven centrally nationally from government. We're participating in and participating in that, and also giving advice and some guidance in terms of what we would like to see within that document going forward. And the second is the serious violence strategy locally led by Paul Edmondson-Jones's team, police and other services, about safeguarding those individuals who are subject to domestic violence and vulnerability. NHS Impact is something that is coming. It was launched a few months ago. We were asked to provide a baseline response, which we submitted as an ICB, but also our provider colleagues were asked to complete that as well. We have been advised that there was going to be a second progress a template that was going to come through to us. However, that's now been stood down. So we're continuing to drive the system participation through our CQI subgroup and the Quality Improvement Network to achieve the aspects of impact that have been identified. QIA we've already touched on, that's progressing and will continue to change as and when needed. And finally, a little more positive news from the CQC, who visited MPFT's mental health services recently. They have now lifted the Section 29A warning notice, and whilst they've identified areas of additional improvement, you know, sort of it was a relatively positive visit. I'll stop there, David, and happy to take any questions.
Thanks very much, Becky. As always, a full report. Just before I do that, I'll just, Josie, I'll just give you the opportunity if you want to add anything to what Becky has reported as exception. If not, we'll just check if there's any points of clarification anybody's got.
Nothing from me, David. Thank you. Comprehensive report, Becky. Thank you.
Okay, thanks very much, Josie. Becky. So just turning to colleagues, any points anybody wants to raise on the report? Again, presumably this is well socialised in stakeholder organisations due to the membership, Becky, which is drawn from everybody on the call today.
Yes, it is.
Who's here, so that's fine. So the recommendations are to receive the report and seek clarification and further action as appropriate. Be assured in relation to the key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated system. Just pause there that the board are content to receive those recommendations. Thank you, Becky. Thanks very much for the report. So we will move into enclosure 8, item 10, finance and performance report. Jackie, I assume you're picking this up. We've already discussed quite a bit of this, but again, just an opportunity to go through the detail of this report and also the performance elements that Phil Smith will be covering, I presume.
Yes, please. So you've already mentioned the financial position at month 5. It's 58.6 million deficit, 45 million adverse variance to plan. We've talked about that. The main areas are we've got slippage on efficiency. We of course know about CHC, but we've also got prescribing pressures, and some of CHC as well is due to increased inflation above the planned element, and that's the same with prescribing costs. We've seen increased inflationary pressures. The other areas that have caused some of the slippage is that we haven't been able to close the escalation beds that we had open at the winter. They've been required to stay open from a performance point of view. And equally, you know, we're undergoing an industrial action. I think we've had every month except for May, and that's having an impact on performance as well. So I'll leave Phil to talk about the performance in a bit more detail.
Okay, Phil, over to you. Thanks, Jackie.
Yeah, thank you, Jackie. Thanks, Chair. I'll just pick up around urgent and planned care in terms of where we are at. We had a further period of industrial action at the beginning of the month, impacting both consultants and junior doctors, which did have a negative impact on both planned and urgent care delivery. At the point in time that I'm speaking, at least, there are no further industrial action dates confirmed, although obviously we're watching the national situation closely. From an urgent care perspective, we are seeing significant increase in COVID-related demand in the last several weeks. That's also impacting on staff sickness levels. and we've seen a particularly challenged week this week, which I think again has been exacerbated by the cold snap that we had last weekend. We remain in a somewhat stubborn position around 4 and 12-hour performance against the national targets. We're working through some refreshes of plans around those, and as part of our Tier 2 oversight with Region, tomorrow morning we will be working through revised trajectories, which we'll share back through committee. We have seen some improvement around our long length of stay patients, which is significantly down against last year, and largely our category 2 response time period has been in the better quartiles of performance compared to other areas. We are, though, still in a highly challenged position around that and seeing significant variation week to week. We've got our UEC improvement plan, which I previously talked about and won't dwell on here, but I will just draw out around virtual wards, which is quite a key thing for us. We've seen significant improvement in both capacity and utilisation in the north of the county, but we are still working into the southeast and southwest to deliver the improvements there. The surge plan for winter is progressing through the system governance routes. The QIA process has been completed. We've gone around some provider boards so far, clinical senate, and it will culminate in ratification by this board next month, although we are also doing a deep dive session later on for board members around some of the detail of that plan. The plan, it is really important to say, is built on the learning from last year and also some quite sophisticated capacity and demand modelling. It's built on principles that protect our elective capacity, but it does have considerable risk attached to it from a capacity, workforce and financial perspective. But again, I will go into more detail on that in a deep dive later on, and when we bring the final plan for ratification next month. From a planned care perspective, briefly, University Hospitals Derby and Burton have been moved this week into Tier 1 escalation, so that's national escalation for elective and cancer performance. So that is now in the same tier of oversight as University Hospital North Midlands. So it's absolutely important from a whole population perspective, given the significant volumes of our population serviced by UHDB, that we keep close to performance there. So the latest information I've seen has shown an increase in 78-week waits for our population at UHDB to around just under 90. We've also got a further 18 at RWT, which is Royal Wolverhampton Trusts. From a UHN perspective, we've now cleared the 104-week waits, which I think is really positive. That's been a stubborn challenge, but made good progress there, and delivered the plan for September, which was 78-week waits, and a further 19, which are our independent sector partner, Nuffield. We are working now to get that route to zero again for the 78-week waits, and also in terms of delivery against the 65-week wait target for the end of year. The first key milestone for that is ensuring patients have had an outpatient appointment by the end of October, where we've got a number of challenge specialties, but we're working to try and improve that. Lastly, I'll just mention cancer performance, which continues to be challenging, although we are seeing reductions in our 104-day backlogs and 62 days, but generally it's colorectal and skin pathways which are proving to be the difficult ones. We've got a range of actions in place around those, and we've also got some NHSE support in around those two sites as well to support us. So I'll pause there, Chair, if that's okay, and happy to take any questions or clarifications.
Thanks, Phil. Thanks, Jackie. Just open it up for questions in a moment, but just one, Phil, on page 61 of the pack, the overview of key underpinning deliverables. Yes. I just had one query. It's very helpful to see the traffic light system there laid out. It's just on the key behind plan with no mitigations identified as yet to improve the position in year is the red score.
Yeah.
Which I guess it's very clear, but I just wondered when we'll be able to get some of those mitigations identified against some of those red lights that we've got.
Yeah, no, certainly, Chair, thank you. And I can just give a brief update through those, because we've got some progress around those. The 76% performance I've mentioned already, and we'll be able to provide an update next month on what a revised trajectory is there, because we do need to meet that national standard of 76% for our performance by the end of the year. The capital investment business case is around additional capacity at UHN, which we've received national funding for, and there are some challenges around the physical build of that, but we are mitigating that in terms of capacity that we're bringing on heading into winter. Bed occupancy does remain a challenge for us, and that 92% target is going to continue to be difficult. Virtual wards I've mentioned in terms of improvement there. The one that is interesting just to mention, which has moved on somewhat, around the clinical assessment service. This has now moved forward as part of the regional procurement for 111. Where the clinical assessment service will form part of that new arrangement. That contract has now been awarded for starting in the beginning of April next year. So you'll see also in the report that we talk about some performance challenges around the current 111 contract, which we're working through the contractual routes in terms of notices and monitoring and action plans around that, but we will be transitioning to a new 111 provider at the beginning of the next financial year.
Thanks very much, Phil, for that. Just pause then. Any points any members of the board want to raise on the finance and performance report? Okay, obviously covered everything off there, Jackie and Phil. Well done, thank you.
Thank you.
So we note the exceptions highlighted in the report. And Megan, I'm just going to ask you if you wouldn't mind just picking up the assurance escalation report for Finance and Performance Committee.
Thanks, David. Yeah, a lot of the conversation that went on in the committee has actually been covered here already today. In particular, I did want to emphasise the remedial notices that have been issued to Totally regarding performance issues with NHS 111 and GP out of hours services. We are having a further report coming back to the next Finance and Performance Committee meeting in November regarding that. I also wanted to mention System Surge Winter Plan, which Phil just picked up. We did approve that plan, and it will, as Phil said, come to the next board meeting. Finance and Performance Committee will also receive a monthly highlight report throughout winter on performance against the surge plan. And then I just wanted to pick up, if I can just move to the right page, just in relation to the outwards development in Burton, which is mentioned in the Primary Care Forum report of the assurance report in the papers on page 73 of the pack. If board members remember, we did have a presentation a while ago regarding this. The outwards development has now been, I think it's officially called unpaused by NHSE, and a business case will need to be completed to allow the project to proceed. It will receive around 8 million, which is a significant initiative within, I think it's the largest amount of money actually within the development, and the ICB, UHDB and Staffordshire County Council are working together on developing that business plan. Thank you.
Megan, thanks very much for that exception and also for the report itself. A lot of summarised detail in there, very helpful. Just pause again if anybody has any comments to raise on Megan's Chair's report of finance and performance for the system. Okay, thank you. So again, we're noting the exceptions highlighted in the report and receive those. Thank you. So move into item 11, enclosure 10, Showkat. If we could take the People, Culture and Inclusion Committee exception report.
Thank you, Chair. And just a couple of things I really wanted to highlight from this report. As you would expect, the continued focus on workforce, and in particular, we did a bit of a more detailed look at Q1 around the reasons for sickness, in particular stress and depression being quite high. and trying to recognise some of the challenges that we have around managing sickness absence. But overall, there's a level of monitoring, and we're keeping a close eye on that. And then, quite significant, we had a discussion around the Freedom to Speak Up report, and in particular, just assuring the committee around recent national events that have been taking place, the follow-up in terms of the Lucy Letby case, and how we need to make sure, not just within our own organisation, but across the system, that the whole area around freedom to speak up is critical in terms of how we move forward. And Tracy and Mission colleagues are doing quite a bit of work in this area to make sure that the discussion with the workforce, making people aware of the freedom to speak up policy, and the ability to make sure we check our systems and processes, that people have the confidence and the mechanisms to be able to speak up. So those are the couple of things I wanted to highlight, Chair.
Yeah, Showkat, again, thank you very much for all you're doing in the committee and for the exception report and for that very important steer that you've just given. Tracy?
Yes, just on the Freedom to Speak Up, it is Freedom to Speak Up month, and part of that is focusing on barriers for people may have for freedom to speak up. So there's a lot of activity going on across our NHS partners regarding Freedom to Speak Up month, and also we're carrying out the self-assessment as requested by NHS England that we do across each of our providers, just for some extra assurance on that.
Thanks, Tracy. So we note and take assurance regarding the reports provided and discussions which took place at the People, Culture and Inclusion Committee. So thank you for that. We'll move into any other business if we can. Don't think I've had any items notified to me of any other business for today. And just want to note it's important that we use our time effectively and efficiently in meetings like the board meeting today to ensure that our senior teams and executive leaders can get on with the day job. So quite a crisp risk discussion this afternoon. So if there's any other business, I will open it up to any member of the public or our guests who may have a question that they wish to pose on any item they've heard from today's discussion. Ian, welcome. Good afternoon.
Good afternoon, Chair. Good afternoon, Board. 3 points. They all seem to interlink as well. Finance, all around the performance and finance report. One's very specifically finance, one's about NHS 111 GP out of hours, and one's about ambulances. There was an increase of £10.8 million in the deficit in month 5. You work with other partners that are involved in low maintenance care, especially the local authorities and the voluntary sector, all of which themselves are in severe financial difficulties. And I accept this is throughout the whole of England and the whole of the ICBs. You mentioned that it's now risk register 25 in the report, and it's mentioned that without further mitigations, the deficit would be £141 million at year end. It's obviously not going to break even. Is the £141 million a worst case scenario?
Thank you, Ian. We'll take that before we move on to the other 2 questions that you've got. Peter, I don't know whether you want to come in on that.
I can begin. I'm sure Jackie can add. So the 141, yes, is before the mitigations in the recovery plan kick in, Ian. So in that regard, it is worst case. But what I'd want to add is that industrial action that might come over the horizon, or the inflation issues that might come, that crystal ball stuff isn't played in because, well, we don't know it's there. But so removing the crystal ball elements and acknowledging that the recovery activity is going to take place and improve the position with those caveats, yes.
Okay, thank you, Peter.
Can I just add?
Jackie?
The one big other caveat is the elective recovery fund and how that plays in. So we are assuming at the moment that we will be able to achieve and receive the elective recovery fund in full. However,
okay.
industrial action means that that is affecting our performance in terms of elective care, as it is with everyone else in the country. And so I think we are waiting to see what NHSE do with that elective recovery fund as well. So that is the biggest risk around the 141. Everything suggests that, you know, the recovery plans and what we put into action will improve that position, with the caveat, I think, around the elective recovery fund.
Okay.
Thank you very much for that answer.
Thank you, Ian. Second question, the 111.
Ambulances, you mentioned your Cat 2 calls have actually reduced. However, the Association of Ambulance Chief Executives have indicated that their data is showing a increase, quite a significant increase of Cat 2 within in September. Given this, it is likely that Cat 2 calls will increase throughout the rest of the year, given the winter, etc. How we don't want the situation we had last year with people waiting hours and hours and ambulances stuck outside in my patch, UH&M, but obviously other hospitals. How assured are you that lessons learned from last year, that you have systems in place that swiftly respond to these trip points? And to me, it's a trip point if an ambulance is stuck outside a hospital for 60, 70 hours and can't get back out onto the road. These trip points will be given the due credence, and to ensure that the whole system, I'm getting a bit muddled here, but the whole system will respond very swiftly to mitigate against massive ambulance handover delays at acute units.
Ian, thanks again for the question. Phil?
Yeah, thank you, Chair, and thank you, Ian, for the question. And you are absolutely right. There is no way that we want a repeat of the challenges that we faced last year. And that is why our plan for this winter, which has been developed by the whole system, is built on the learning from last year, is based on what we consider to be a robust capacity and demand model. But that being said, it is not without considerable risk from a number of perspectives. So I'm not going to sit here and say it is a risk-free plan, because it is not. But there is a plan there, and we are working through also how we do escalation and risk share across the system, so that we do not end up loading risk all in one place, which I think was one of the key learning points from last year. And absolutely, we worked very, very, very hard, believe me, in terms of those ambulances and making sure they're turned around in a timely way, and making sure we've got a robust system response. Thank you.
Thanks, Phil. Thank you, Ian. Third question.
Right. Early on this year, I questioned the amounts of money going to the NHS 111, the new contract. You extended a contract, NHS 111 and GP out of hours. And Paul, finance director, said the extra monies were basically for more work. Obviously, your recovery plan is dependent on all providers delivering to a recovery plan. And obviously, totally, I know them as Vocare, but I think they got absorbed by Totally, or NHS 111, GP out of hours services, are key providers. I noted that there have been action plans and remedial plans, and they haven't been met by the provider with a satisfactory standard. So you're not satisfied with the standard of the service. When is Totally going to actually abide by its contractual obligations? Have you any kind of date for that, please?
Thank you, Phil. Is that you're going to take that as well? Yeah.
Yeah, thank you, Chair, and thank you, Ian. Yes, again, Ian, absolutely right to raise the risk around that. As I mentioned earlier, we have been part of a regional procurement for a new 111 contract, which commences next April. The provider of that will be DHU, who currently provide for the majority of the rest of the region. So it will be one provider across. So in the meantime, as you say, totally formally, Vocare provide the services for us and have done, I think, for around 10 years, certainly predating myself here. They provide 111 out of hours, GP out of hours, and a range of other primary care services. I've got detail around those. I'm conscious of using the time now, but I'm happy to share separately if it would be helpful. That we've got a quite detailed log in terms of performance notices that we have issued around 111 performance, because clearly, although the provider will change in 6 months' time, we've got the most difficult period of the year to get through. And last week I reached agreement with Totally around some recovery trajectories for answering calls within 60 seconds, for the abandonment rate, and for clinical callback within 20 minutes, all of which are currently outside of contractual allowance. So we'll be working very closely with Totally to ensure that those remedial action plans are delivered, and we continue to escalate this and monitor through our finance and performance committee, and it is indeed on our risk register as well. I hope that helps.
Right, thank you for that. If I could quickly come back on that, Chairman, if possible. Right.
Yes, fine.
Totally, will not be having the contract next 24-25. How are you managing the transition? Because there was a transition earlier on, earlier this century, to GP out of hours service in North Staffordshire, and some situations it fell off the cliff. So how are you managing the transition?
Yeah, okay. If I'm all right, just come back on that, Chair.
Yeah, please do, Phil.
And thank you, Ian. Yeah, that transition is absolutely essential, because we cannot miss a beat in terms of that 111 provision. We've got a meeting next Tuesday with the new provider and with Totally and with ourselves to start talking through what that transition plan is. Now, for me, to do this sensibly, we do not do a cold cut off and a cold switch on. We do a transition, and we phase things over in a very controlled way, because 111 is too important a service, too critical a service to afford any downtime, particularly within the next 6 months. So I will be looking to agree a phased plan, and certainly Totally have committed to me that they will work with us to ensure that transition is done in a safe, managed way. And also I'm reassured by the fact that DHU themselves took on the contract only 12 months ago-ish for most of the rest of the region. So they've already been through a number of transitions, in fact, very recently. So they've got that organisational memory there. But it's absolutely right that we're planning now in October for what will ultimately be a changeover at the beginning of April next year. Thank you.
Brilliant. And I'll take you up on your offer, Phil. Thank you very much.
Yes, thank you, Ian.
Thanks, Phil. Ian, thank you for your attendance and for your support and questions. Just pause. Any further questions anybody attending the meeting today has for any of the team on anything that you've heard during the course of the meeting? Okay, thank you. So we'll just move into meeting effectiveness. And at the start of the meeting, I referred to the Leadership Compact, and just want to check that everybody is happy with the meeting, had an ample opportunity to raise any issues, either of a risk-related nature or concern or otherwise, and that we have followed the essence of our compact. So just pause, take silence as approval for that. Thank you. We'll close the meeting then, if we can. The date and time of the next meeting is the 16th of November. And again, that meeting will be held via Microsoft Teams. I understand the meeting, Tracy, in December will be a face-to-face meeting at the hub, but next month's will be Microsoft Teams. And
correct,
yeah. And just before board members sign off this call, I was just wondering, Jill, if it was possible to actually take a 15